Everyone, so this begins our chapter 14 work on abnormal psychology, or what we like to call clinical psychology. But we'll use the word abnormal just because it's used quite a bit in your book as well. But I typically like to say clinical psychology because it's not very abnormal to have mental health issues, as you guys are starting to learn or have learned. Again, this is going to be Unit 8 in College AP World, and this one is combined with Chapter 15 for College Board and the test, and hopefully you get something out of it. This was a recording that I did last year and there's 3 different sections, so I'm going to have those posted for you and have some videos posted for you also that you can watch, and some reflection questions that you can think about when you're watching some of the videos. You don't have to watch all of them, but if you'd like to, there's some really interesting ones on bipolarism and eating disorders and OCD and schizophrenia, so they're there for you to use. Again, you are going to be using this for this time for studying, so want to make sure that we give a little bit of things, very little to do for the class period and assignment so that you can begin studying. You should be studying for a month for this test. So I've got some things along the way to help you with that. So let's get started with the stuff in section 1. So what does abnormal psychology include? There's a bunch of slides I have in here that are not in your book, so you're going to want to listen. I'm going to teach you some things about the field itself and then also the history today. So what does abnormal psychology include? Common characteristics of different disorders. There's main categories and of disorders themselves. There's treatment and prevention. There's theories of abnormality and why that happens. And then a recent focus has been that social cultural piece that we have in our textbook and the historical influences on that. Psychopathology, remember, is the study of origins, symptoms, and development of psychological disorders. So one of the things I want you to do for today for one of your assignments is to look at the perspectives in explaining abnormal behavior, and we're going to go over that next time. Just take a stab at it. It's good review for you to go over your perspectives and apply it to something new. So abnormality is relative. What is abnormal? So look at the different examples that are there. A man kissing another man, a woman refusing to eat for several days, a man barking like a dog, a man driving a nail through his hand. Think about how people would have thought about Jesus. A woman slapping a child, and a woman making a shrine and offerings to her dead husband. All of these are seemingly abnormal in their own context and also their own culture or societal norms. And so when we talk about abnormality, it's really important to keep that perspective that it just depends on what social norms are out there. So common misconceptions of disorders. One, the idea of somebody being crazy is different than normal behavior, but actually, as they've stated, there's only a matter of degrees between crazy and normal, quote unquote. And a lot of that can be determined again by social or cultural context. So all of us may double check if we lock the door, but some of us with OCD might decide to check it 50 times. In traditional Hindus in India, remember they don't eat hot food of specific types about 6 months after time of mourning, and someone else would find that that's very abnormal. So those misconceptions of what is normal and what isn't are very matters on cultural, and it's very small degrees of change. To someone who's acting weird and unpredictable and unconventional, as the guy you see in the picture there, it's really too simplistic and very unkind to use those kinds of words. So we try not to talk about that and use those words because it really doesn't have any true meaning. It doesn't characterize symptoms and causes and length of the issue. So we need to be careful of how we actually talk about mental illness. One of the things to be careful of is our own use of language when we talk about behavior, and those things can create negative stereotypes. So people saying, oh, you almost gave me a panic attack, or oh, my mom's so bipolar, quit being a psycho, my OCD is coming out again, kind of like diminishes what people actually go through when they have these disorders. And so we have to be cognizant of that and help with the social stigma. The stigma of abnormal behavior can lead to a lot of prejudice and discrimination. People may not feel very comfortable being around someone with a disorder, and so they may lack, some kind of friends. They may be socially ostracized because of that. They get a lot of stereotypical responses and might get even rejection from family and friends. And there's really a big public misunderstanding of the causes of abnormal behavior. And I think if more people learned about that, we would start to reduce that stigma, which we're trying to do now. So mental illness and its stereotypes in terms of violence and the effect of media on there. You see some typical male role models in movies that have been seen as being psychotic. Although there's some instances in our own lives for shooters and mental illness, they found that a majority of crimes are not committed by mental ill people. And the media helps to portray people with psychological disorders as very negative, and it reinforces that stereotype. And those stereotypes can either be helpless victim or evil villain. 5% of normal TV characters are murderers, while 20% of mentally ill characters are seen as killers. So a lot more mentally ill are seen as murderers. And then 40% of normal characters are violent, while in some manner, while 70% of mentally ill are seen as that way. And then they looked at a Canadian newspaper, 40% of any articles dealing with mental illness in the context, were put in context with crime and violence. Substance abuse and mental illness, and whether they were letting mentally ill people out of an institution and then testing whether or not those people became violent. Mentally ill people became more violent if they also had a substance abuse issue as well. Substance abuse in those studies showed to have generally lead to more violent behavior. There was a slight increase with people who had extreme, bizarre sort of delusions or hallucinations. And then there's other family factors that can also lead to violence, such as mentally ill people that have a family history of violence, poverty, abuse of drugs and alcohol again, and those are strong predictors of violence. Generally, mentally ill people are more likely to be the victims of violent crimes and not the opposite. As you can see in that chart on the right there, the stigma is really far-reaching to possibly our law enforcement. This particular chart talks about how law enforcement authorities saw a rise in justifiable homicides by officers. So in the line of duty, they were shooting people, and because of that, the police officers were making that on the part of having more encounters with people that are mentally ill, and that justified having the officer having to defend themselves. And these kind of charts and misinformation is something that can perpetuate sort of the stigma of mentally ill people. Cultural influences on abnormality, as it talked about in your book. Abnormality is culturally defined to a certain extent. Some behavior is consistent, but there are some things that are historically have been and present have been based on culture. Each era and society, so even historical, has its own interpretation of abnormal, and I'm going to show you that in just a minute. Cultural specific disorders are found all over the planet and globally, as we've talked about. For instance, demonic possession is still something that some African tribes, for instance, have a common diagnosis and still use it, and they've been using that for thousands of years, some religious aspect of why you're abnormal. There's one called running amok, and it consists of episodes of indiscriminate violent behavior in young Southeast Asian men. So you're just for a time being, you're just running amok, even though you're doing violent behavior. And then just as we read about in our textbook, the difference between social anxiety between an individualistic culture and a collectivist culture like Japan, and how that social anxiety is based on us not wanting to be judged versus us not making other people uncomfortable. So you can really see those abnormality differences in cultures. Sorry about that. So common characteristics of abnormality is departure, violation of social or cultural norms. They are statistically rare behaviors, so they're seen as abnormal. So something that would be considered something to put in DSM-5 would be something that rarely happens. So it's not these normal common behaviors with just mild distress. It's a pattern of maladaptive behavior or psychological symptoms that cause distress. And the most important thing is that it impairs the person's ability to function and then causes that distress as a result. So all the categories that are placed in your book are all the different categories, and under those include the 260 disorders in DSM-5. Now the APA is involved with DSM-5 and has a definition of abnormality, and they say that it is behavior that is atypical or statistically uncommon with a particular culture, or that is maladaptive or detrimental to an individual, to those around that individual. Such behavior is often regarded as evidence of mental or emotional disturbance ranging from minor adjustment problems to severe mental disorders. I like this definition too because it does talk about the individual being affected, but also those including friends, family, partners, things like that. Now, we're going to get into this in terms of diagnosis, but I wanted to introduce it a little bit early. When we're talking about DSM-5, we don't really use those 4 particular components to diagnose. When mental providers are basing their diagnosis and they're trying to fit it into a category of DSM-5, they look for the following things, and you'll see that kind of trend with some of the reasoning behind the disorders. One, they would diagnose if a person is in danger. So it's the 3 Ds: danger, defiance, dysfunction, distress, and duration. So danger, does the behavior cause danger to the individual or others? Deviance, is the behavior considered deviant? And again, that would be based on social norms. Dysfunction is the behavior causing impairment to themselves or someone else. Distress is the behavior causing personal or family societal distress. And duration, has the behavior been occurring for a specific amount of time? And the DSM manual has criteria for this kind of thing. For example, depression, the signs need to be consistent and meet the other criteria for at least 2 weeks is the duration for that, for it to be able to be considered to be diagnosed as depression. So DSM-5 has been written by hundreds of professionals over 12 years and many reviews and trials. It's used to have codes and provide a common language for professionals so that they're labeling and diagnosing using similar language. It goes over symptoms. It talks about criteria that must be met to diagnose the disorder. It talks about the frequency aspect, like I said, the 2 weeks for depression. It talks about the typical course of a disorder and the risk factors. And it also is good because this diagnosis is going to be used for people to get medical expenses covered by insurance companies, which if they didn't have the diagnosis would not occur. This is for the United States. The WHO or the WHO, the World Health Organization, created their own classification called the ICD, which does match some of the disorders in DSM-5. So the history of abnormal psychology in the world, but also specifically America, I'm going to cover, is a pretty interesting one that I thought I would share with you. So in the Middle Ages, again, those demonic sort of supernatural possession of demons was the response to abnormality. They would drill a hole in the skull to let the demons out, or chain a person in the basement. And people would actually pay to see these people chained up to see what abnormal was. So it's a very cruel way of looking at mental illness. In the late 1800s, we get the introduction of the psychodynamic and behavioral approaches. And so they're treated a little bit differently. And again, it's that unconscious desires, and maybe that's the idea for abnormality, and behavioral approaches of why they had abnormality occur. And in the 20s and 30s, abnormal behavior was put in homes away from families who could not care for them. It took a turn for the worse, especially after World War I and the Great Depression, when families in the state were having issues with paying for so many people to put in a home that would help, or an institution that would help them care for their mental illness. And so we get our eugenics program that was created in the United States in the 1920s, where they have mentally ill patients are forced into sterilization. And sterilization, again, is the fact that they, male and female, they're not allowed to reproduce. And this is warranted by the state. In fact, as you can see from the chart on the right-hand side, sterilizations in Indiana did last up until 1983. And I think a lot of those may have been in mental illness institutions, and I can assure you probably it also was in prisons and jails as well. So Fort Wayne School had, that is a picture of the School of the Feeble-Minded, which was a place just north of here that did sterilizations. And again, it was to combat poverty and disease and crime, but also to deal with mentally ill people and having them not reproduce and pass along those genetics. Rural people in Indiana were marginalized and were not contributing because of their poverty, and certain groups like the tribe of the Ishmael that you see there on the right were posing an undue burden on the state due to irresponsible living and out of wedlock birth rates. And so they increased the rates of sterilization in the 1930s and the Great Depression because of the lack of funds for the government to care for these people. Post-World War II saw a little bit of an incline in sort of support, and especially in the 1960s with John F. Kennedy. In 1952, that's when we have the creation of DSM manual. And then in the 1960s, there's a great political influence by JFK to deinstitutionalize people from hospitals. It wasn't that successful as a really grand notion, but this whole population of people were not getting help that they needed, as feeble as some of that help might have been in the past. But the idea that he did it was an important notion that disability and mental illness needed to be a public focus. DSM added some categories in those years as well. And in 1980, they had a good system of classification. In the 20th century, we add more cultural aspects of classification, which you can see is important there. We did add some classifications, though, as like I said before, because of the influence of insurance companies on some of the authors and trying to get people to take more drugs because there's more classifications. So that's something to keep in mind. And disorders that were added over time were eating disorders, ADHD, and social anxiety. Homosexuality was considered a mental disorder in DSM-2 in 1968, and then in 1973, the Board of Trustees of the Psychiatric Association voted to remove it from the list. And the vote was, not close, but if you can see 5,800 to 3,800, there was still a lot of people that wanted the homosexuality to be listed as a mental disorder, but it was taken out because the vote was larger that it should be removed. So criticisms of DSM, some classifications are done with little research and less reliability, is one notion that was not really touched upon in your book. Some of those classifications were sort of broadly put in there, and some criticize that they should or shouldn't be in there. It includes some conditions that are too normal to be a disorder. So extreme sadness after death, there's sort of this blurred distinction between normal unhappiness with actual mental illness. There's some arbitrary cutoffs, which you have to make in a manual at some point. So the difficulty of doing that is that if it's too low, then more people are diagnosed. And if the cutoff is too high, then less people get help who need it. So it's a very hard balance to draw that line as to when somebody has a disorder or not. There's definitely some gender biases, which historically has some influence on that. And some work was, again, driven by drug companies. So the prevalence of psychological disorders, there was a study done by Kessler of 9,000 Americans ages 18 and older called the National Comorbidity, I'm tired, sorry guys, survey replication called NSCR. It had 2 years of face-to-face interviews, and they asked participants about the symptoms that they had. in the previous 12 months at any point in their lives, and about any risk factors such as abuse or substance abuse that may have contributed to those. Comorbidity, which if diagnosed with one disorder, usually have another one. 1 in 4 adults with mental illness also have a substance abuse disorder as well, and you can see the child there just having, ASD or eating disorder or mood disorders. Like there's usually some kind of diagnosis where you have some other disorder as well. And also in the study, they looked at the age of onset, and depending on the disorder, it does vary, as you can see in the chart in your books. The lifetime prevalence in 1 out of 2 adults, 46% had some kind of symptoms at some point in their lives, and the rates were high globally as well. That 1/3 of those had in different countries, 17 different countries had a rate of mental illness. You can see some cultural stigma examples, with Nigeria being only 12% having mental illness at some point in their life or some symptoms, and 50% in the United States. And that might be due to disclosure of actual symptoms as being, something that was a cultural stigma and people were not sharing information. The implications is it's high, but some of those symptoms are very mild, so it's not necessarily something to be alarmed with, and something that would reduce stigma if more people knew about that. Treatments in this study that Kessler did, the NSC found that most people with symptoms received no treatment in the past year, 59%, and those who had treatment had it through a variety of different doctors, although most of the care was coming from a regular doctor and not a mental health professional. And this includes the US, not just other countries. And that treatment was really inadequate, not up to the guidelines listed, and especially in DSM-5 or the World Health Organization descriptions. Some mild symptoms diminish over time, and so even if some of these treatments were ineffective treatments, people might thought they were actually, the treatment itself had caused the symptoms to reduce and not just time, so people were getting constant treatment that was inadequate as well. We also need to look at the fact that developing countries that are more in poverty, are less likely to seek help than developed countries, and that may be due to resources. Okay, so let's get into our anxiety disorders, PTSD and OCD for the day, and then we'll be done. So anxiety, feeling of tension, apprehension, and worry that hits during personal crisis and everyday conflict. So most of us have a realistic threat where we have anxiety. Everyone has it, especially now with everything going on. And our anxiety is adaptive and normal, and it usually shuts off when the threat is gone. Some of us may be experiencing some more of that tension and worry because the threat has not gone down, but we have a way of putting those things aside, and that is part of like the normal response to anxiety. We have a physical alert response, that's your fight or flight, and also a mental alert where you really focus your attention when some kind of threat comes around, where you're scanning the environment for that threat. 1 in 4 people will be affected in their lifetime in the US. I think that's probably going to rise more after this epidemic is gone. And it's found in every culture, but generally across the board with most of these disorders, we see a lot of commonality in females more than males. So anxiety disorder is maladaptive, and like we said, in terms of the characteristics of disorders themselves, it disrupts everyday activities, moods, and thought processes. Anxiety is the main symptom, although anxiety, as we've seen, is a symptom of other disorders. This one is the main symptom. And something to keep in mind is to look at that chart on the right there and look at everyday anxiety that a lot of us do experience and are able to either put aside or it goes away. And then the difference with having anxiety that's actually something that would cause someone to diagnose someone with a disorder. There's 3 distinct features compared to normal anxiety. One, there's irrationality. Threats are definitely perceived, and they're very exaggerated or non-existent, and they're really not proportional to the actual situation going on. That makes it exaggerated. It's uncontrollable. The alarm reaction that we just talked about cannot be shut off. Even if someone realizes that they're being irrational, it's just an uncontrollable feeling that they have, and so forth. And it's very disruptive. As we said, this would interfere with daily life, but also relationships, academic performance, job, things like that. Now, GAD is generalized anxiety disorder. That's very specific, and it's very global, persistent, chronic, and excessive apprehension that's constant and ongoing. And it's constant tension and anxiety is really widespread. There's worry about many issues excessively, and that life experiences have little or no apparent justification for any of those types of excessive worrying. The free-floating anxiety is attaching anxiety to any object, person, event, or even nothing at all, and that feeds into the idea that there's no apparent justification. It just goes on to something. When someone stops worrying about one thing, they start to replace it with another worry. The causes of this are environmental, psychological, genetic, and other biological factors. So for instance, if a brain was wired for anxiety due to genetics or epigenetics, it can emerge with triggers like problematic relationships and stress in the environment. And then if someone is born psychologically with a shy temperament, they might be overwhelmed in new situations and over time just continue to have that overwhelming feeling and develop this disorder in adulthood. Now, panic attacks and panic disorders. So a panic attack is an episode of extreme anxiety that rapidly increases in intensity. So symptoms, could be hot flashes and chills and sweating, numbness and tingling in the hands and dizziness, hyperventilation, heart palpitations and pounding heart rate. People feel like they are nauseated and have like a choking sensation. And there's a surge of physical arousal like we talked about before, but the feelings are not just the heightened arousal like fight or flight, but this like feeling of terror and the fact that they feel like they're dying or losing control or going crazy. And some may even think that they're having a heart attack. This will peak in 10 minutes and then gradually subside. The causes of this are definitely stressful experiences. It might be an injury or an illness, and usually a stressful period of time in their life. The most common triggers might be death or grief, a separation or divorce, or some kind of interpersonal loss. But it can come from nowhere, and that's the thing that's frustrating is it can be a reaction where you don't even think that you are feeling anxiety, and then a panic attack comes on. The disorder is frequently and unexpectedly comes on, and the frequency can vary, which makes people worry about, when the next attack will come. So it can be 7 in a month or 1 in 6 months, and so then you can develop other disorders because of that. Agoraphobia is that fear of suffering a panic attack or any other embarrassing or incapacitating symptom from a place that you can't escape. So things like or symptoms of agoraphobia are sudden outbursts or rage or intense emotions, devaluation of relationships or extreme idolization of someone, the fear in enclosed spaces, a feeling of loss of control and trembling, not wanting to leave their home. So they avoid crowded places and elevators and transportation. And one interesting one is they're also afraid of losing their bodily functions or emotions in public. So that means like they're afraid of urinating in public or some kind of fecal output or having some kind of sexual desire that they would act upon in public that they know would not be acceptable. So why do panic attacks or panic disorders occur? The triple vulnerabilities model is the first model to look at. They are definitely, in this model, they think that there's 3 different reasons for panic disorders, that somebody has a hypersensitivity that we've discussed in previous chapters of that fight or flight response. If they feel a fluttering heartbeat or dizziness, it will spawn them on that they're scrolling out of control and that there's something wrong, desperately wrong with them. They do have a biological predisposition to anxiety, so genetically they are predisposed. And then they have a lower sense of control over potential life-threatening events, that they have that sense that they don't have control more than others. The catastrophic cognitions theory is that it does recognize the oversensitivity for that physical sensation, but it's the meaning behind this experiences that, you know, they sort of make it about it's some catastrophic thing that's happening to them. So if they climb a set of stairs and their heart rate goes up like any normal person, they feel like they're having a heart attack. And so the meaning behind a lot of things creates this vicious circle that adds to that physical arousal piece. And as you can see on the right-hand side, you know, a panic attack has some of the, you know, the characteristics of a heart attack, but there's a lot of different things that are just not even close to comparing both of these. So it's something that's not a reality or a rational thought for someone having a panic attack. And then the cultural reporting of certain syndromes resemble panic attacks. The Spanish phrase attack of the nerves, it has some similar characteristics like heart palpitations, dizziness, and losing control, but they also become hysterical and they'll scream and swear and break things or hit or lash out with other people. But because of their cultural way, they elicit social support, so they're not embarrassed about it, and so it's more seen in that culture as an acceptable way to respond to stress. Causes of the attack of nerve syndrome is severe stressors, including especially involving family. And you can see that more like collectivistic, sorry, culture coming out in that disorder. Funerals, accidents, family conflicts are main triggers, and that really shows that cultural aspect of it. Panic attacks and panic disorders, and in terms of phobias. And so this is one of the more interesting things of just like phobias, and there's phobias for everything, as you can see on the table 4.2 in your book. Fear of dust and wind, fear of red objects, fear of acquiring a phobia is even one, fear of your own voice. You know, there's all really interesting ones that they have identified. And these are really unusual, and those are unusual for people to have. There are some more common ones to have, for instance, and that's just this persistent and irrational fear of specific objects, situations, or activities. So a specific phobia, or once what was called a simple phobia, is the object can cause a full panic attack. So the fear interferes, like any of the other disorders, with daily life. The realization that that the fear is unrealistic. They do know that it's unrealistic, but they can't help it. And then in terms of who has it, 13% of the population will have symptoms in their lifespan. And again, women are more prone than men. And as stated in your book, Oprah Winfrey, there's some other celebrities as well that have phobias, had a fear of chewing gum. And you can see the cause of it because her grandmother, as a child, used gum around the house. That environmental trigger caused her to have a phobia of chewing gum when she became older. Specific phobias have 4 main categories. Fear of so the phobias can fall under one of these: a fear of particular situations like flying or driving, elevators, or crowds; a fear of features of the natural environment, so heights would be one; water or storms; the fear of injury or blood, such as needles or having some kind of medical procedure; and then fear of animals and insects, like snakes, spiders, dogs, slugs, and butterflies. Yes, there's a fear of butterflies. On the right-hand side, you can see a picture from your book that has the fear of holes, trypophobia, which is the fear of holes, like you can see in soap bubbles or chocolate bars or anything with any kind of holes in it, or even a pattern of holes. It doesn't have to actually have holes. So dart frogs in the lotus seed that you see above, the dart frog could trigger somebody because it has seemingly holes on its smooth body. And then, of course, the lotus seed has quite a few. This disorder is interesting as well when we look at just in terms of situation and so forth. And then some of these could be fear of animals. A second type of phobia is a social anxiety disorder, one that is most common and one that's been added to the DSM-5 manual. And that's a paralysis of fear of social situations. And the main component of this is that people feel like they're being judged or evaluated, which is very different from other cultures. They do realize their fear is excessive, or some realize their fear is excessive or rational, but not all do. So this one, even though they know that a lot of the other phobias, they know it's sort of ridiculous that they have a fear of something like slugs. The people that have social anxiety disorder may not think that that is an excessive fear or something that's irrational for them to worry about other people judging them. So social situations elicit fears of dread and anxiety, even thinking about doing that, and it definitely interferes with daily life if people stop working and start going out and to different public places. And again, it's more prevalent in women. So the cultural social anxiety disorder in Japan affects young males, and it has an extreme social anxiety and avoidance of social situations as well. But it's not an embarrassment of being in public because they're a collectivist society. It is about how their appearance or expression or body language or something that they do will offend, insult, or embarrass others. So you can see how the difference in both the societies of individualistic and collectivistic have an effect on why somebody has a social anxiety disorder. And then in terms of why these phobias occur, it's interesting to review back to some of our things about learning principles. So classical conditioning, as you can see there on the side, an overprotective parent induces anxiety in their child. So if the child, if dad's afraid of dogs, one day he sees a dog approaching while he's playing soccer with his son, and his son's happy and wants to pet the dog, but he sees the fear in his dad's eyes. And then his son signals his dad's fear and notices his dad's looking at the dog, and the son automatically couples dad's response and learns that dogs should be feared. So overprotective parents, as opposed to healthy parents, can create anxiety and phobias in their own children. So think back to little Albert and how he was classically conditioned because of a traumatic event. So we develop a conditioned response of fear to a conditioned stimulus like a dog. So if a dog bit someone, then it created a conditioned response of fear, and it may only have to happen once. We know that from little Albert, it happened very few times before he developed that phobia for the rest of his life. And then that person generalizes that phobia to any dog, not just the dog that bit them. Another learning principle is operant conditioning, so your negative reinforcement. So by avoiding dogs, you're negatively reinforced by the relief of not having anxiety. So you avoid dogs so that you don't feel anxiety. So that is a way of applying operant conditioning. And then observational learning is again like Bandura and observing the fearful reactions of others that are acting as a model. So we look at parent reactions like that we said just before in the dog example, but also media and film and pictures of disasters or plane crashes can, if introduced too early, can really have a dramatic effect on someone and their phobias. And then lastly, besides learning principles, also biological preparedness in the evolutionary perspective, that people just are reacting to certain phobias because of survival threats. So if fear of snakes and spiders would be just a normal or even exaggerated evolutionary reaction to that threat. But also people being scared of things like cockroaches or slugs would be associated with a survival threat such as disease or being infected, and that's passed along from ancestor to ancestor. So PTSD is the second one, and it's something that I'm sure a lot of us know a lot about after probably learning about veterans and effects of war, and also maybe even abuse, sexual or physical abuse that can cause PTSD. And it's long-lasting disorder that is due to an extreme trauma, and it's the event that causes the disorder, not the internal going-ons of the person. So that event needs to be something that causes intense feelings of horror and helplessness. And it's not an anxiety disorder, but it has a lot of the similar emotional, cognitive, and behavioral factors of an anxiety disorder. 51 million Americans, more than 2 times the number of women, have PTSD. And you can see even in other countries that, children in war zones and in places like the Middle East, maybe in Syria, especially today, that 3/4 of them have moderate symptoms, not mild symptoms. And then a list of people that would be affected by that was first associated, obviously, with veterans. Now we see natural disasters, like 60% of children after Hurricane Katrina had mild symptoms, physical and sexual assaults and shootings, terrorist attacks, like the 40% of military veterans in Boston had increased emotional distress after hearing about and being around in the city when the Boston bombing went off. Rescue and relief workers and people that rescue people or find people that have deceased in a tornado, relief rescue or 9/11. They might any emergency personnel, police officers, firefighters may have PTSD. Anyone who witnessed an injury or death, and then even trauma in the media, a terrorist attack or war could trigger PTSD. There are 4 clusters of symptoms of PTSD. First of all, frequently recalls the event, and that is unwanted and or intrusively replaying it in the mind. It's triggered by unrelated events, but it just continually triggers, and it can come back in the form of flashbacks as well. I worked with some sexual assault survivors where that they definitely didn't want to think about being sexually assaulted, but those thoughts came back in their minds, and then those flashbacks were what caused some major distress, and they would literally be able to see a movie playing in front of them of the experience. And it was very traumatic for them to go through a flashback. So number 2, the person also would avoid stimulus or situations that tend to trigger those memories, so they don't have to go through that distress. And then they experience different altercations in terms of their moods and emotions. They might blame others. They might have guilt and fear and a sense of persistence. They might have loss of relationships and activities because they're just trying to retreat. They could also have a loss of appetite and nightmares and drug use and that isolation because of it. And then 4th, there's an increased physical arousal, which we've talked about. And a lot of vets from Vietnam will talk about sleep disturbances and being easily startled over little things, problems concentrating, irritability, flashbacks, anger outbursts, things like that. Why do some people develop it and not others? 3 reasons. 1, heredity for one. 2, personal or family history of a disorder, which are more likely to develop PTSD when exposed to a traumatic event. So you're already sort of in that mindset and predisposition. And then depending on the magnitude of the traumatic event or having multiple traumas as well. Risk factors also include life stressors that have large magnitude and a lack of support and maybe even some neurological issues as well. But the 3 to the left are some of the more prevalent ones. So ACD, one of my favorite pictures is to the right there of Howard Hughes with his tissue boxes on his feet. I'll get to that in a second. But this is a person's life is dominated by repetitive thoughts, obsessions, and compulsions and behavior. So it's classified as an anxiety disorder. And you can see that as Howard is a germaphobe. So he doesn't want to wear anything but tissue boxes on his feet. And the symptoms include a few things. 1, the obsession. So this repetitive, intrusive, uncontrollable thoughts that cause distress. Normal worries have factual basis, even if we exaggerate them. These obsessions have little or no basis, and they're really far-fetched and not in reality. So the fear of germs, the fear of dirt, in doubt in turning off, appliances and simple tasks. Howard Hughes had a fear of germs due to his mom's constant fear of contracting polio. So that learned behavior and is classically conditioned. And she was worried about him getting sick as well. He sat naked for weeks in a germ-free zone because he was so scared of getting germs. And then again, you see him. He was important for aviation in the United States, and there's him later on in life where he died in isolation wearing tissue boxes on his feet. So obsessive compulsive disorder also includes compulsion. So these are repetitive behaviors. That's one of the things that you're going to look at as a second part of your assignment is to look at the clip of Jack Nicklaus in As Good as It Gets. Notice the plastic gloves on his hands as he's holding the dog. It took him a while to pick up that dog because it was dirty. But you'll see him display some behavior that's OCD as well. And this is ritual behavior that must be carried out in a specific pattern or sequence or even number of times. And they don't like the ritual, but they know if they don't do it, they're going to have extreme anxiety. So the behaviors that they'll have is overt physical behavior, so washing hands, checking doors, entering and re-entering doorways until they're exactly where they want to be, which could be the exact middle. And then covert mental behaviors, not outright or overt behaviors, but things like counting or reciting certain phrases to yourself in a pattern, a specific time of day or a certain time in which you do something that creates the anxiety to go down. So OCD has characteristics of obsessions and compulsions. So 3/4 of obsessive compulsive patients suffer from multiple obsessions. So you look for that in the clip As Good as It Gets. What are the multiple obsessions that he has? Half report more than one compulsion, but it's more common to have both and not, you can have either obsessions or compulsions, but it's more common to have both obsessions and compulsions. And number 2, belief that failure to perform the ritual will result in some catastrophic event, and they're unable to resist that force. So, for instance, a woman believes if she doesn't get dressed in a certain order, her husband will die. Her husband dying obviously is a catastrophic event for her. And that those with covert mental behaviors have superstitious mental thinking, or what they may call as magical thinking, and that's how they know these catastrophic events are going to happen. And that it's similar in different cultures, although the content of the obsession or the compulsion would mirror the culture. So, for instance, in Nigeria and India, somebody who compulsively washes their hands is not about germs like it would be in the United States. It would be something of their concern in their culture would be religious purity. So you're washing your hands so that you are pure in the eyes of their God. In your book on table 14.3, there's some common obsessions and compulsions. So obsessions, contamination is one, pathological doubt, the feeling uncertainty about having accomplished a task. So that's checking and rechecking. Violent or sexual thoughts, the fear that if you have harmed or will harm another or engage in some sort of unacceptable behavior. And then compulsions, washing of the hands, checking, counting, and so forth, symmetry and precision, so the need for objects or actions to be perfectly symmetrical or an exact order or position. So that's like the OCD that most people talk about. Monica from Friends is OCD because she has to have the position exact and in the right order. Otherwise, they can't function if there's something that's not perfect on a desk or a mantle or whichever. So I think that's the one that most people will commonly just kind of throw around, oh, I'm OCD. Explaining the causes of OCD, all of them are biological at this point that they have found. And the first one is in relation to neurotransmitters. There's a deficiency in norepinephrine and serotonin, and they know this because of the drugs that are given with those two neurotransmitters actually decrease the symptoms. They also found that there's dysfunction in specific areas of the brain involved in fight or flight and frontal lobes, so your thinking and planning are affected. And then what makes you regulate your movement and go into these very repetitive behaviors, your caudate nucleus, which is the part that you can see on the right-hand side there, that sort of wraps in that midbrain area. All of those areas of the brain, including those in the fight or flight and frontal lobe, increase the chances of feeling overwhelmed with doubt and lack of physical control. Thanks, everybody. Return back to the module and you'll see what you're going to do next.